Hematologists were involved right at the beginning once they identify a patient with high risk. So first thing, okay, the first thing that we stratified, we assigned our high-risk patient cases. Yes. And for example, in placenta previa, accreta, percreta, once they are diagnosed, it was agreed that once they are diagnosed, involve the hematologist right from the beginning at the diagnosis stage rather than admission stage. We will prepare the blood, we will improve the patient condition. You will see later on how we are working. So then we will go into, once we identify the risk patient, we will know the proper clinical management of PPH. So the responsible team are assigned, those who are the anesthesia people, we know who to talk to, the group of obstetrician and the hematologist, the whole team of the hematologist. Our role is to prevent. As a hematologist, not only to identify the high-risk cases, I need to improve the patient clinical condition if she's anemic, if there is an underlying coagulation problem, probably even if she needs a lot of blood, she's having an underlying alloantibody or that might delay her process, or her blood transfusion. So prevention is very important. I didn't go into the detail of our preventive measures that we are taking because of the sake of time. Yes, please. So, okay, this is the optimizing hemodynamic status that we go around. We take care, even if we can prepare the patient before, during, or after. Yes. Our aim is to diagnose, to prevent shock rather than to be shocked by the situation, and to treat properly the patient. And even the story doesn't end once this patient is stabilized. We follow up the patient even post-operatively because we want to make sure that she is out of the ICU to the ward, discharge, and even follow up in the OPD. Good. So we updated our policies. And we started to change some of policies we have in the lab. For example, no need for, we receive at any time blood request for any surgical procedure should be sent 2 weeks before the operation, and for blood transfusion at least 5 days before the procedure. From our side in the lab, we try to solve the other 50% of the risk the patient she might have. We try to solve the delay by implementing a new strategy. Yes, please. And among which is that the sample, usually all the samples from ICU, MOT, or high-risk cases, they are handled in a special way. They are handled in hand by hand, and they are, click please. Hand by hand, and any request or tube is left for ICU patient high-risk cases, they should not be put on the desk. If anything is by chance we saw any tube left on the bench from ICU or MOT or high-risk cases, we investigate this issue. So it is hand to hand, and we take all the precaution to finish the test as urgent as possible and to contact and convey the message or the results to our colleagues. For high-risk cases, for high-risk cases, bleeding, we do the test frequently. Go ahead. This is one of the steps that we did, and I think most of the success of our treatment is relying on this. We separated ourselves into two parts. I guide the group in the ICU, and the other group is in the lab. I will explain this later on. We introduced because of a distance entry, we were the first one to introduce point of care like machine of CBC. And for the last 2 years, I'm looking for a coagulation test that do the 3-parameter for the ICU for such cases. We are using the thromboelastography, but unfortunately, in the literature, its use is so limited, but we can use it now. We have a plan that with every case, major bleeding, we are introducing it. We have to build our own experience with it. For the blood bank, because we receive daily around 30 cross-match, and this every cross-match takes half an hour, so we were the first lab to request the fully automated kind of blood bank system, not to tackle the high-risk cases, but at least to work instead of the technologists for those unnecessary cases where the cross-match, type and screen, and our technologists focus on the high-risk cases. We have, flip it quickly. No, not that quick. Go back. So you can stop on this. No, the platelet in PPH, we try as much as possible, according to the case, to maintain it between 50 to 75. Despite the literature, they were pushing around 1.5 to push the fibrinogen. I never used 1.5 as a guideline for me. I always push for above 2 gram per liter. So we introduced, even in our PPH high-risk cases in severe bleeding, I introduced so many with the help of the anesthesia people. We use a tranexamic acid in a dose of 1 gram, repeated every 30 minutes. We have recombinant factor 7 has been used several years without. I'm using it as a prophylactic, as a low dose, high dose. I'm using it especially now for high-risk cases when we know that this is percreta or a very high risk of bleeding. Before I put it as a guideline, when we exhaust our resources of 10 or 8 packed cells, now no, for high-risk cases, I used it early, but on my decision, only on my decision. Clotafact is one of the factors that one of the drugs families that we introduced this year. And it is a human product. We used it during this year. It's a human fibrinogen. The one vial has 1.4 gram, and it is in a small volume. What's nice about it, I'm not marketing for the company, but this is my experience, and still my experience is premature. So I'm using it for the high-risk cases. Whenever I'm faced with a high risk of bleeding, and the bleeding we know now, if the patient is really bleeding from everywhere, we know. I noticed that the fibrinogen is the first thing that to be knocked down, especially in percreta, in high-risk, in amniotic fluid embolism. The way the fibrinogen knocked down, you need a continuous resuscitation with the fibrinogen. That's why, go back, please. I've been using Clotafac successfully with our patient. The last one was one of the worst amniotic fluid. Patient resuscitated and then arrested, and then once she's resuscitated, she went into bleeding from every orifices. We were losing her, but with the help of a Clotafac, this is the time I used a lot of dose of Clotafac because I didn't have time to wait for the cryoprecipitate to be thawed. So I used around 9 gram of Clotafac with the help of cryoprecipitate. Still, I'm not, still if you go over literature, there is no consensus with the use of recombinant factor 7, even with, with the Clotafac, even with the recombinant factor 7. But I'm using them, and I'm happy with the way I'm using it in the hospital. I use it because I compare it with the cryoprecipitate. It is readily bottled within less than 1 minute. It is ready for me. I can save the patient by the time thawing is there. The thing that urged me also to do it, because it's very well virally inactivated with the 3 method. Cryoprecipitate is still a human product. So I'll be waiting for the consensus, probably 10 years, I don't know. Okay. This is the way it is.
Time.
So I'll just show this. After we finish, we do discussion. Once the patient stabilizes, we discuss this thing with all our team and also with the lab to know where is the substandard during this case had happened. Okay. So this if you can flip it quickly. Whenever we have an alarm, emergency plan started the way I told you about. But what is the important message I want to give is that the redistribution of the hematologist. We redistribute ourselves into 2 teams. One team in the ICU, guided by me. One of my colleagues goes into the theater because the anesthesia people and the obstetrician, they are so busy. Sometimes I need to know the amount of blood, how much. Is it oozing from the bed of the pelvis? This minor detail, they are so quite busy and they cannot tell me. Because at that time, I can tailor the use of recombinant factor 7 or Clotafac. And we have the major hemorrhagic emergency box. Also, it is once we have a severe bleeding, 2 units is sent as a rescue, and then we prepare this box as emergency. This constitutes of 4 packed red cells, 4 FFP, and 6 cryo. Go ahead. This is how we monitor. Okay. Finish. Finish this. It's okay. This is how we want to push. You want to push the hemoglobin around 8. the platelet around 50 to 70. 50 is safe, but some of the cases, you know, there is impending, it is going on so fast, push it 75 is better. Okay, postpartum management is also continuous with the patient because at that time we have to know, does she need thromboprophylaxis, improve anemia, and also we need to counsel them in the OPD because the risk of recurrence is 10% in those cases. Okay, go ahead. Finish. So, stop. This is, I quoted from one of the articles. It represents the whole issue. Having a good protocol that has never been practiced, similar to a football team that studies its play but never works through the timing on the practice field. Or like, back please. خليني أخلصها. Back please. يصير أقول أخرجوا. Anyway, this is the way you want to work it. You want to work it in an organized way, no delay, in a harmony, in a teamwork. Thank you.
Thank you very much. Thank you. Have a seat here, please, if you don't mind. Prof. Yang, would you mind joining me on the board, please? And Dr. Mustafa, please, if you don't mind. This is a question time. If anybody have a question, please do. Thank you. Dr. Khaja.
Thank you. Thank you, sir, everybody, for excellent presentations. My question is to Dr. Mustafa, please. Just with regards to bridging, you mentioned that enoxaparin is inefficient in bridging. Can you hear me?
Can you make it louder, please?
Okay, it's just a question with regards to bridging. When you spoke about bridging and dual antiplatelet therapy, if we have a patient who's having surgery, say urgent surgery or emergency surgery, and he fits the criteria to stop the dual antiplatelet surgery. Usually you stop only the aspirin, but we continue the aspirin, you stop the clopidogrel, and you said that bridging is not efficient. So the normal practice, or what we do and quite normally, most people do, is that they give a therapeutic dose of enoxaparin. Should we do that, or should we not do it altogether because it's not effective?
It has been shown, thank you for the question, it has been shown clearly that there is no benefit for low molecular weight heparin or unfractionated heparin. It doesn't work, you know, it doesn't have the same mechanism of action of clopidogrel or aspirin. So basically, we have tried it, other people have tried it, studies has tried it, guideline has came out with it, it's not effective, it doesn't work. So you want to give it for other purposes, that's different. But you want to give it for prevention of stent thrombosis, has nothing. It's not going to make any difference.
Thank
you. Any question, Doctora? Doctora, yes? Dr. Huda, please.
A question to Dr. Mustafa Rida, again. Regarding what you've mentioned about over-investigating the intermediate and high-risk patient, mind you, the low-risk patients, that we shouldn't be doing this provided that they have good functional capacity. I used to have the same belief till I came here, till one of my colleagues, who's probably not here now, you probably know who he is, was opposing me, saying that if you're not going to investigate people and rely on their history, then you're going to end up with surprises because people don't give you good history. And to tell you the truth, I had not many, but one or two surprises where people were telling us that they have good functional capacity, they can walk for long distances, and they can do this and that, and then they end up with a problem, and then you go and do an echo on them, and they end up with a very low ejection fraction. So how do you find your experience, since you're obviously seeing a lot of these patients with this regard?
Now, we know that patients don't benefit much. Nowadays, the practice is shifting. If you look at the percentage of coronary interventions being done today, we know that over 80% of the coronary interventions nowadays in well-respected centers are done for ACSs, basically an STMI, unstable angina, and ST elevation MI, and only 20-25% of patients are for those who have stable coronary artery disease with progressive uncontrolled symptoms. So we know that patients with stable coronary arteries, they do better and they do good with good medical therapy. And there are many trials showing that. One of them is Courage trial and some other trials. So we know that coronary intervention does not improve the outcome for stable coronary artery. This is number one. Number two, if you have a patient who's been asymptomatic and stable on medical therapy, and I assume that the patient has definitely coronary artery disease. I'm not talking about somebody who does not have a coronary artery disease, has stable coronary artery disease and has reasonable functional status. We are talking about a functional capacity of more than 4 minutes. We are not talking about somebody who's going to be running the marathon. We're talking about somebody who's able to walk from here to the parking lot. So if he's able to do that, and there are some criteria or some sort of methods of estimating their functional capacity. You are not asking the patient to do exercise in order to create a knowledge of their functional capacity, the day-to-day activities. So one of them is the Duke's criteria for assessment of a functional capacity. If you're able to go to the toilet, that's 2.5 minutes, by the way. If you're able to go from your bed to the toilet, it's 2.5 minutes. So basically, you are asking very simple question. The problem with the surgery, the non-cardiac surgery or any cardiac surgery is the hemodynamic shifts that Dr. Yang explained, as well as the volume status change during the procedure and the bleeding. So if you are able to control those factors, you're going to be able to control your patient. So doing unnecessary testing is going to basically create more trouble. This is my feeling, and I believe, you know, for a patient to go for a laparoscopic cholecystectomy and to have a stress myoview, given that he's asymptomatic or, you know, reasonably asymptomatic and reasonably functional, doing a stress myoview and finding a small area of ischemia in the inferior or lateral wall, and then going for a coronary angiography and ending putting a stent, and then delaying his procedure for another year. And nowadays, as you know, we are all utilizing 99% of our stents are drug-eluting stents, third generation, second generations, and so forth. So basically, delaying your procedure for 1 year, subjecting to the patient for acute cholecystitis, gallbladder abscess, pancreatic problems, and so forth. So I believe if you're able, in a reasonable way, to assess the functional capacity of the patient, I think that would be more than enough to assess the function. Now, I'm not talking about LV function, you know, this is something else. I'm talking about evaluation of the coronary artery disease, and this is the most important thing, by the way. Again, looking at the patient, if you want to assess the presence or absence of heart failure, again, this is a clinical judgment. It's not an echocardiographic judgment. Echocardiography tells you the functional status of the heart, yes, but it doesn't tell you the clinical. It's not equal to the clinical parameter, although nowadays there are some parameters in echocardiography which can tell you the volume status. But clinical judgment is more important than any other ancillary testing. I mean, of course, if you hear a loud murmur, if you hear, you know, crips, if you hear, you know, so many stuff, you will have to go further and investigate this patient for the sake of that particular diagnosis, not for the sake of going for a laparoscopic cholecystectomy. And of course, you're not going to take a patient with an acute ST elevation MI for surgery, non-cardiac surgery, and you're not going to take a patient with active heart failure, class 3 or class 4 for an elective procedure, definitely. We're talking about, reasonable, unreasonable, unnecessary testing for patients who are going for simple procedures. I think that's for me is too much of a kill to do these types of tests. I don't think you should do tests just because the patient is going for a non-cardiac procedure, just for that particular sake. It's a waste of, most of the time, I'm not saying all the time, most of the time it's a waste of resource.
Prof. Yang, want to add something yet?
I think another way of approaching this is if you look at 100 people that you do the investigations on, how many of those people actually go on to have uneventful events or non-cardiac surgery? And this is why I showed the Mason study from 1995. This is not new. We always knew this. What we found when you look at 100 people coming for non-cardiac surgery and we decide to do all sorts of investigations, the result is the investigations are not harmless. And we end up with the risk-benefit ratio of doing more harm than actually benefit. And the trouble is we do have maybe 0.5%, maybe 1%, depending on where you practice, maybe even a higher percentage of patients who will get into trouble that you don't think that they're going to get into trouble. If my comment earlier about echocardiography means to you that you should do pre-op echo, no, that's not what I meant. Because there are good trials to show that pre-op echo does not change anything. What I meant is when something goes wrong, you really should have the capabilities to now put in the TEE probe to quickly tell you what's going on. That's the 0.5, maybe 1 or 2% of the cases that you don't expect something to happen and something happens. That does happen, and I'm not being unrealistic in saying that. However, when you have someone who is stable and coming for elective surgery, the more tests you do, the more harm we know we cause.
Okay, you want to add something? Yeah.
Just one more thing. I think the problem sometimes is the medical or the fear from medical legal, litigations, and problems. And one of our colleagues mentioned that before the meeting that, we all know that there is no benefit from these tests, and sometimes it reflects more harm than benefit, but we are worried about, getting, sued, and one of the members of the committee of an investigation team can say, why didn't you stress my view? Well, you have all of the data available. The data is available, the trials are available, the guidelines which has been put is available, and basically it's very well argumentative. There are more sincere people in the medical community than those who are not sincere. This is my belief. Thanks.
Yeah, I just want to clarify because you did mention echo in a positive manner, and I think you're really talking about the benefit of echo in an acute episode, not as a pre-op assessment tool. Is it?
Sorry, you're talking about the echo? Yeah. With any of the cardiac output monitoring, and in the context of we have diseases that we can never predict how they're going to behave. For example, I used the example of the physiology of the acute coronary syndrome type 1. I can never predict when the plaque's going to rupture, and I've also had a colleague one time giving an anesthetic to a patient who just happened to decide to have a pulmonary embolism, a saddle pulmonary embolism, right in the middle of the case. Well, who's going to predict that? You can't predict that. You can do all the pre-op tests you want, you can't predict that. That's when you need the capability to quickly diagnose what's going on. And right now, the tool that has reliably given us that is the intraoperative echo, the TEE.
Any more questions? Yes, Dr. Khashti.
Dr. Hussain, thank you very much for you and for your team. Very interesting lectures. My question to Dr. Ruhuddin, you mentioned that one patient dies every 2 minutes. I couldn't get it. What did you mean by this?
It's globally, not this. It's
okay, which is very. It is a really big number.
Yes.
I don't know how is it in Kuwait. If you have any comment. And my second question: did you evaluate the protocol which you are using now, which you talked about how you do it and all that? And if you see it successful, are you planning to implement it in other hospitals? And actually, I enjoyed the discussion at the end. Thank you very much.
Thank you for your question. As regard to the hemorrhage of the massive bleeding, it's a problem all over the world. I presented from a registry of 2003, but even if you follow up to 2016, still major hemorrhage in as in the form of PPH is still as a direct cause of maternal death. So I will not be surprised if 2 minutes one mother die from one reason, direct or indirect. As regarding whether to implement what I said at the beginning, this is still a premature kind of experience. And I have been asked by several bodies that why don't I apply such my knowledge or this kind of protocol into all the hospital. But frankly to tell you, Dr. I'm responsible of all the risk I'm subjecting the patient and all the benefit. So this has to come through a consensus kind of a group. Yani we meet together. I cannot push one kind of a treatment into and push it to everybody. If anybody wants, we have to sit. We have to the way we are doing it. It should be through kind of a collaboration. Since we have a kind of a teamwork, it's a collaboration between the obstetrician, the anesthesia people, ICU people, as well as the hematologist. We can sit and reach to a consensus. Whether I found kind of, probably I can review or see whether it is successful or not, and the timing, how much I'm controlling the bleeding. Before the bleeding can take more 45 minutes, 1 hour. During 1 week, it came by surprise when I started to implement this kind of strategy or kind of a treatment. By luck, we had 3 cases. The first one was a patient that all of a sudden, when they called me, she was in a shock. So it was a little bit late. So when we started to introduce the treatment, we could manage her. But it took time. The second case, because we were well prepared, in less than half an hour, or probably 45 minutes finished. The surprising was during the weekend, we had one of the worst cases of percreta according to the obstetrician, and we could finish it in 30 minutes. You know, there was a bleeding, but was well controlled, and this is not because of my effort. I have a very skillful doctor at that time during the week, and we have very skillful and professional people in the ICU and the obstetrician. We are a team. The good thing about maternity, if for example, we have a high-risk case, they accept if I say I want a consultant to do that. احنا نمون على بعض بهالدرجة دكتور. عرفت شلون؟ إنه for the sake of the patient, we can suggest who do the operation in one of the time. So, and I think my experience is still, I need to build more and more. لأن everybody has the right to question me why on earth you are introducing a drug that there is no consensus still on and using it. But I really happy with the drug. لأن for the last 2 years, alhamdulillah, ما في morbidity related to the bleeding. The timing of controlling the bleeding is an indicator that you are not in a big fuss, because of the bleeding. بعدين the amount of the consumption of the factors like the cryo, the FFP, definitely relatively أقل, because it was a short talk. Within less than 48, I couldn't prepare my statistic.
Last response for Prof. Yang, you want to respond back?
I apologize, I will keep it very short. One of the things about this sort of events, for most centers, it occurs maybe 2-3 times a year, maybe 4 or 5 times a year, and in some centers maybe once every 2 years. And then the problem becomes the team isn't used to practicing this together. To give you an example, we had a drill, and we call it a massive blood loss protocol. There's an alert that goes out hospital-wide. And to our surprise, all the porters who need to transport the blood ran to the emergency department and waited for orders. And we wanted them in the birthing unit. These little things that if we did not practice, when it actually is occurring, the people are not used to it, and you don't have time to correct it. And this is one of the examples where we'll say, I don't know if Dr. Polke is here, where the simulation, where the drills actually need to occur. I'd like to ask a question. You mentioned a lot of the blood taking and being waiting. Are you using point-of-care testing?
Point of care testing. Yes, it's available in most hospitals in Kuwait now. A lot of ICUs and theaters do have them. Yeah, making a difference. Thank you very much. Thank you, everybody. I'd like to thank my distinguished speakers for this informative lectures, and start the new session.
I'm sorry, we don't have time to break, so we're going to continue and move to the next session. Let me introduce Dr. Adil Sarraf, the head of the critical care department in Mubarak Hospital, and he will move on with the next session.
Thank you very much. I'd like to thank the organizing committee for inviting me. Can you please put the slides back on? Thank you. In the United States, you're supposed to show your conflicts of interest before you talk. So these are my important conflicts of interest. This is my family. These are my unimportant conflicts of interest. I have a few patents that the University of Pittsburgh owns. I've been a consultant to several companies, and I have about 4 NIH grants. Okay, monitoring. There's a fundamental monitoring truth, and that is that no monitoring device, no matter how accurate or insightful its data, will improve outcomes unless coupled to a treatment which itself improves outcome. And thus it really doesn't matter what you're monitoring if you're not going to be using it to manage the patient differently. There was a very nice study that was done, organized through the University of Pittsburgh, but a large multi-center study called Process, in which the investigators compared early goal-directed therapy with EGDT, with protocolized care that didn't require blood, or just having the intensivist see the patient in the emergency department if they came in septic shock, and to manage them. And what that study, published in the New England Journal, showed was that it didn't matter which specific process you used, the outcomes were the same. And if you looked at the monitoring that was used, for example, on the top, the amount of central venous catheter was high in the early goal-directed therapy group, but only about half the patients in the other 2 groups that weren't required to put in a central venous line put it in. So those data do not tell you, don't put in a central line. Those data tell you that if you want to put in a central line to monitor or to infuse fluids, please do so, but don't do it because I told you, do it because you think it's the right thing to do. You probably do not need to measure central venous O2 sat, because if you look at the amount of fluids that were given in the 3 groups, they were almost identical. Furthermore, in the ARISE study from Australia, they found the exact same thing. We do not need to have a very defined protocol or monitoring. What we need is an intelligent physician at the bedside understanding the physiology, which is what I'm going to show you in a minute. We can take a certain degree of comfort and pride in being critical care doctors, because when the group in Australia reviewed the